There you go. You're good.
Perfect. Okay, we should probably close, or well, it might get steamy hot in here. Not that way.
That's on there for posterity. Let the steam room begin. Pediatric.
It begins in the steam room, pediatric heart failure. So we'll define heart failure, we'll go over physiology of heart failure, we'll spend very little time classifying it, and then most importantly we'll look at what heart failure looks like in the transport environment. So what is heart failure? Heart failure, as you can see here, is really a heart unable to meet the metabolic demands of the body. Sometimes, in most instances, it's the heart that's unable to meet it, but in a few instances, the metabolic demands outpace the ability for the heart to compensate. But regardless, heart failure, the end result of it is circulatory failure, and we'll talk a little bit about that in further detail. So there's a few equations that you need to know. One of them is this formula here, cardiac output equals heart rate times stroke volume. And the reason why this is important is because there are two ways for a heart to either maintain or increase its cardiac output, by increasing heart rate or by increasing stroke volume. And because we typically cannot acutely change our stroke volume as far as increasing it, the heart typically compensates by tachycardia to increase its cardiac output. Decreases of acute, no problem. In instances of acute hemorrhage or dehydration, stroke volume is obviously going to be affected, it's going to be declined, and therefore the way for the heart to compensate is to increase the heart rate. So for every cardiac patient that you see, you need to consider 5 factors. Preload. Really, preload is thought about volume at the end of the heart being relaxed. Rhythm, of course, because even if all cardiac components are operational except the patient has a dysrhythmia, that can dramatically affect cardiac output. Rate, as it ties into our formula here, heart rate times stroke volume. Contractility, the ability for the myocardium to squeeze blood. And afterload. A way to think about afterload is the pressure that the heart has to work against in order to eject blood. So for every cardiac patient, consider these 5 factors. So we talk about the pathophysiology. We'll go over this very quickly because it's very complicated, and time doesn't allow us to go through it in greater details. But during heart failure, the muscle cells, or the cardiac myocytes, must adapt. And they must adapt because there's a physiologic strain or a pathophysiologic strain put upon the heart in order to maintain cardiac output. And from a chronic perspective as well, one of the things that we think about is wall stress. And wall stress is really a more accurate way to look at afterload. But it's really takes into several considerations: the pressure of the ventricle, the size of the ventricle, and how thick the ventricular wall is. So because of increased wall stress of a heart in many instances during cardiac failure and other mechanisms that are in place, there are 3 major adaptations that the heart goes through in heart failure. And one of them is the Frank-Starling mechanism. And the Frank-Starling mechanism basically looks at the ability of the myocardium to stretch during end diastole. And end diastole, again, is a passive process. The heart is relaxing, it's filling with blood. And as it fills with blood, the myocardium, the myocytes, it's going to stretch. And as they stretch with more and more volume, as you can see, and with muscles, it has the same relationship. It's able to squeeze a little bit better, and therefore you can see that as the myocardium, as the end diastolic volume increases and it stretches a little bit more, because of that stretch, it's able to contract and improve cardiac output. But there comes a point when this stretch is so great towards the end here that in fact it becomes detrimental. In heart failure, a very similar relationship happens. With heart failure, the myocytes are not operating at full capacity to begin with, and hence you see a dampened effect. But when you get into cardiac failure, what happens is the same thing, but it's further augmented in the normal heart. That stretch is only good to a certain point, but too much of it is a bad thing, and it starts to affect cardiac output. So if we increase preload to a certain degree, we can improve our cardiac output, but of course there's a limit to this. The second one is, the second adaptation to cardiac failure are what we classify as neurohumoral activation. The body senses that the heart is sick. It tries to compensate. So from the adrenal glands, it releases the catecholamines epinephrine and norepinephrine. And what happens here is very similar to what happens in the effusions that we run into the ICU. The norepinephrine will cause vasoconstriction. The epinephrine helps with the heart squeeze of inotropy, for example. But because of this, what happens is that you get increased demands, metabolic demands of the heart, and increased oxygen demands. What happens too is that you have increased calcium entry into the heart cells. Calcium helps with contraction, and so that's an important element. But too much calcium is not a good thing. Too much calcium can also cause cell death through a process called apoptosis. And the last thing that happens is that you get activation of the renin-angiotensin system, and really what happens with that is that the body wants to retain water so that it's able to stretch the myocardium, as we discussed in the previous slide, and also causes vasoconstriction. Chronic heart failure results in the remodeling of the myocardium, and typically what this means is that you start putting on myocardial volume and mass, and that helps the heart generate enough force to push blood forward. But the more muscle you have on the heart, the more oxygen demand you have, and the contractility is impaired. So again, with most of the remodeling that happens in the body, there's a benefit, and there's often a poison. And so you get potentially a better squeeze, but the poison or the expense of it is increased oxygen demand and impaired contractility at some times. When you're thinking about heart failure, there's two broad categories that you can think of: acute versus chronic. Oftentimes in the PICU, we see either acute presentations or acute on chronic. And then you can also think about diastolic or systolic failure as well. And systolic failure can be kind of summed in a general term that it's an inadequacy of the ventricle to squeeze. It's an inadequate ventricular inotropy, as it's documented on the slides. But when you're talking about diastolic failure, again, diastole is a relaxation process, and diastolic failure can be defined as the abnormality to relax. And in some instances, this is because you have very, very thick muscles, for example, because of chronic remodeling, and the relaxation state is abnormal. This is a nice little summary. I wouldn't expect you to ever memorize it, but it kind of classifies the more common heart failures in systolic and diastolic categories. And you can see that from a systolic perspective, as we talked before about, is that significant arrhythmias can cause significant problems with their cardiac output. In the PICU, probably the most common disease that we see for intrinsic heart disease is acute myocarditis, but these are further examples that do come into our unit, but not with the same amount of regularity. And then what's very interesting is you get some situations where you have high output failure. For example, anemia, when your hemoglobin is low. There's nothing wrong with your preload, your afterload, your contractility, your rhythm and rate, but because your hematocrit is so low, the only way to provide enough oxygen to and metabolites to your cells downstream is for your heart to pump at a very, very high rate. And over time, that can result in high output failure. And of course, diastolic heart failures here These are the cardiomyopathies, infiltrative, things that cause the myocardium to become stiff. In kids, what we see probably the most often is hypertrophic cardiomyopathy, but we do see the other ones as well. So from a clinical pearls perspective, and this is going into the transport environment, very important thing is to be able to identify these patients early, because in the transport environment, when we're on the phone discussing the patient with the referring center, oftentimes they're described as patients that have a primary respiratory issue, or they're irritable, and the referring center is concerned about CNS pathophysiology. So sometimes it can be quite subtle, and in infants this is particularly true. They may present with failure to thrive and or poor feeding. They may become diaphoretic while feeding, increased work of breathing, and irritability. When you're talking about toddlers and children, again, it can be subtle as well. They can have poor growth or poor appetite, fatigue, not being able to keep up with their friends in the playground, or simply shortness of breath. Now, do these patients need ICU once they're identified? And although there is no consensus statement that has been written, there's a few things that are documented here on the slides that you can think about. Thinking about, does this patient need critical care? And more importantly, perhaps the patient is stable in the referring center, but what is the trajectory of their expected disease? So some clues, as you can see here, and some that we see quite often, and others that that can perhaps overlap with other disease presentations. Central cyanosis, tachypnea, pallor, coldness of extremities can mean different things in different contexts. So again, picking up the cardiac patient and then asking yourself, what is the best destination or disposition for this patient after transport? From a pulmonary perspective, sometimes we'll hear pulmonary rales over the lung bases, wheezing in an infant with significant volume overload, sometimes pleural effusion, and hyperinflation being a compensatory mechanism for fluid on the lungs. Very, very important for a cardiac exam is the abdominal exam. Is the liver enlarged? Is the spleen enlarged? And I cannot overemphasize this. This is a very important factor. I write down ascites there, but realistically, picking up clinical ascites is difficult with small volumes. And if you are able to pick it up clinically in a child, most likely they have other manifestation of cardiac disease. Feeling pulses is important and can give you certain hints as far as the pathophysiology that's occurring in the heart. Are the pulses weak? Are they rapid? Are they thready? Do you feel an abnormal pulse pressure, for instance? Tachycardia is a manifestation of many pathophysiologies. It's very non-specific. But arrhythmias is something that you need to consider in all your heart patients. When you're listening to the heart, again, it's in a lot of kids, particularly when they're young, it's very difficult to get a very strong cardiac exam unless you listen to 100 of hearts because of how tachycardic they are. But do they have an accentuated second heart sound? Do they have a large heart, for example? Do they have murmurs in diastole or regurgitant type murmurs? Again, I wouldn't expect you to be able to classify murmurs, but I would encourage you to listen to as many hearts, normal hearts as you can, so that you're able to differentiate abnormal with normal. When you're clinically thinking about these patients, I think it's a nice way to stratify these patients into a 4x4 table. Is the patient wet or dry, and is the patient cold or warm? Now, most of us in this room, or all of us, should be dry and warm. And by that I mean warmth comes with adequate perfusion to your peripheral, and dry basically means that we should not be volume overloaded. And as I talked about in earlier slides, the body compensates by retaining water. It becomes volume overloaded because it wants to stretch that myocardium, and consequently a lot of the patients that present with acute or chronic or acute on chronic cardiac failure will be wet on exam. Wet being wet lungs, sometimes ascites, signs of volume overload, hepatosplenomegaly, etc. So when you think about patients in cardiac failure, Are they wet? Do they exhibit signs of volume overload? Or are they cold? Do they exhibit signs of peripheral perfusion issues? Now, it's important to be able to classify it because depending on what box they are on this 4x4 table, you're going to treat a little bit differently. So for instance, all of us in this room would be in box A, the warm and dry. However, if you're in box B, for example, warm and wet, one of the things that you may have to think about is a diuretic. They're warm, meaning they're well perfused, but they're wet, which is a sign of volume overload. So therefore, in order to maintain or to retain normal homeostasis, perhaps what they need is a little bit diuresis. So this is a nice little way to think about your patient, wet or dry, and cold or warm. In the transport environment, we will have a point of care gas analyzer that's able to do simple labs. You will also be in many centers that are able to run common labs, and there are a few things that may be able to help you. Anemia, for example, with a low hemoglobin, will be a very helpful indicator for some signs of cardiac disease. It may be able to explain the tachycardia that we see in an otherwise healthy patient. White count, for example, a lot of the times our acute myocarditis will present in the setting of fever and an elevated white count. How are the kidneys doing? With an elevated BUN and creatinine, perhaps that indicates decompensated heart disease in a sense that the kidneys are underperfused. And then electrolytes are very important, as you know, with any sort of arrhythmias. Simple things that perhaps you can correct. Hypokalemia, for example, hyperkalemia, hyponatremia. These are things that can affect contractility of the heart and can affect also whether the rhythm is going to be sinus or not. Arterial blood gases, we have RRTs that are on our transport team that are able to do arterial stabs if necessary and if indicated. We are able to determine hypoxemia simply from a SAP monitor and hyper or hypocapnia from a capillary blood gas. ECG is very important, and we review common ECG findings and abnormal findings in PALS courses, but again, I cannot emphasize it over enough, or that dysrhythmias can dramatically affect your cardiac output. Chest x-rays we go over in another talk, but there are certain indicators of cardiac disease in chest x-rays. A large heart, for example, pleural effusions in later heart diseases. Things like curly B lines where you can see lines all the way to the outermost markings of the heart, for example. So little subtleties again on chest x-rays that will be able to contribute to the overall picture that you're painting with that patient. I won't go over curly B lines because we go over that in a subsequent talk, but they're typically lines that are on the outermost part of the pleura in a vascular distribution, apparent vascular distribution that tend to be parallel and in the same sort of orientation as the ribs. And we talk about this in a subsequent talk, and there I say parallel, again in the orientation with the ribs, curly B lines and curly A lines. So treatment, as we talked about, we'll go back to this 2x2 table that I discussed a few minutes ago. The goal of all our cardiac patients is to restore them in box A, having a warm patient that's well perfused peripherally and dry, meaning not volume overloaded. If we go to B, the way that we can get these patients perhaps to A is with very gentle diuresis. And again, when it comes to cardiac patients, the key is to be as patient as the patient will allow you, and to be very careful anytime that you're giving volume or taking volume off or starting inotropes or et cetera. You want to be able to titrate it and to see clinical response before escalating therapy too rapidly. If you're in the cold and wet patient, you want to restore the patient to box A. Some of the things you need to think about first are, how do I get this patient warm first? The patient is obviously under-perfusing their peripherals, and therefore there is an indication that perhaps the pump needs a little bit support. So again, depending on the patient, one of the things you may need to think about is perhaps this patient needs heart support. Maybe they need a little bit of epinephrine in order to support the heart. While it's hard to support it and the patient warms up because the perfusion is better, then perhaps it's a time to start thinking about diuresing the wet patient so that they become warm and dry. A cardiac patient that is cold and dry is a patient that is very frightening, and this is a patient that needs to come to a tertiary center as soon as possible. So you cannot paint cardiac patients with a broad stroke, but I'm going to give sweeping generalizations here for you to think about these things. Again, have a high index of suspicion in any patient that you see for cardiac pathology. Use your history, your clinical exam, and the investigations really as your guide. And that's not only with cardiac patients, but that's with all of your patients. Try to decipher acute, chronic, or acute on chronic. And why this is important is because it may help you decide disposition, rapidity of transport, for example, and even therapy that you will initiate. And then ask yourself, is this primarily diastolic or systolic failure, or is it both? Is there a history of cardiomyopathy in this patient? Is this an acute onset after the patient has gone through a febrile upper respiratory tract infection, etc., etc.? Again, your history, your clinical exam, and your investigations should help guide what type of failure or broad category this patient will be in. And then try to think about your patient. Is your patient wet or dry, and are they cold or warm? And the last thing is, anytime that you're thinking about giving fluid to cardiac patients, you need to be very, very careful with it. And that's where the abdominal exam comes in very handy. Before giving any volume, it's very important that you feel the liver, and after you give volume, it's very important to reassess the liver. And you can give fluids rapidly, but give fluids of small volumes, either 5 to 10 mils per kilo, and then constantly reassess before giving another fluid bolus. So again, we talked about the warm and wet patients here. These are patients that typically will require mild diuretic and perhaps even afterload reduction. The cold and wet we talked about is that perhaps these patients need their myocardium to be supported, epinephrine, dopamine, for example, and once they become warm and wet, then we can start gently diuresing them. And again, the cold and the dry patient is the one that are very, very difficult to treat. These are the patients that will require cardiology and intensivists to be at the patient as soon as possible. These are the kids that may need ECMO or ventricular assist device support. So in conclusion, the most important thing I can tell you is to always keep cardiopatophysiology in the back of your mind. It often mimics respiratory diseases, so keep that in the back of your mind. The outcomes of these patients depend on our ability to identify these patients early and to provide the appropriate care as soon as possible. Myocarditis in the pediatric population is the most common form of acute failure, and it's often one that's missed even in large tertiary centers. And finally, use your history, your exam, and your investigations to help guide your differential diagnosis.